Welcome to the NJ Spotlight Roundtable series. In this program, the impact of Medicaid expansion on New Jersey's healthcare system. This program was recorded in Trenton, New Jersey on March 7th, 2013. This program is brought to you by AmeriGroup Real Solutions in Healthcare, the Hospital Alliance of New Jersey, and the Nicholson Foundation. Panelists on the program today are Dr. Poonam Aleg, former commissioner of the New Jersey Department of Health and Senior Services and a board member of the Common Sense Institute of New Jersey. Raymond Castro, senior policy analyst from New Jersey Policy Perspective. Susanna Yanni, president and CEO of the Hospital Alliance of New Jersey Incorporated. John Kern, CEO of AmeriGroup New Jersey Incorporated. And State Senator Joseph Vitale, Vice Chair of the Health, Human Services, and Senior Citizens Committee. Moderating the program is Andrew Kitchenman, healthcare reporter from NJ Spotlight. In this program, Chapter 2, the panel continues its discussion of the issue. Moderating the program is Andrew Kitchenman, healthcare writer for NJ Spotlight.
And I want to follow up on that big question, hopefully with all of the panelists to get their perspectives on, with the implementation, what do you see as the biggest challenges facing the state? And do you see the pieces that are currently in place, such as not knowing exactly the amount of funding that the navigators are going to receive, the navigators that are going to be funded through the exchange, and then the mandates and penalties that are going to be in place under the ACA? Do you see those things that are in place being enough to reach the state's goals, or do you think that additional steps will be needed? And if so, what steps? And Senator Vitale, I think, has already somewhat touched on that through some of the legislation that he's talked about, but I'd be interested in your thoughts on that, Senator.
Well, I think that for a time we did really good work in outreach, and when the state was providing their share of dollars to the through the Department of Human Services, that was matched by federal dollars, so it was $1 million state, $1 million federal. At least at one time, we were effective, and we were able to reach, provide dollars for organizations and others and that could do the enrollment. There was some level of advertisement. There were bus placards, and there were, pencils and, yardsticks. But, we also did some real thorough sort of advertising and marketing program that we had hired people to do, the state hired people to do, that actually made a difference. And we saw that we stopped marketing the program. We saw a significant decrease in those individuals who are understanding the program, knowing that it existed, and actually enrolling in the program. So there was a real cause and effect by not having those dollars here, because for quite a long time, and even today, I think in some ways it's the state's best kept secret. Family care, Medicaid, and even though Medicaid is, for a childless adult, you have to be, so poor, below 24% of poverty is unimaginable. So I don't know even how you can find someone who lives below 24% of poverty unless you check under the overpass. So, it's a horrible way to live. And for those above 24%, there is nothing. And so this is, again, why the exchanges, or why the expansion is important. All that's from 30,000 feet and very important. I think the other thing we should talk about, too, is the provider network. And certainly being able to have enough primary care providers or docs and nurse practitioners, in the field, on the ground, doing this work. We know we have a primary care physician shortage in New Jersey, and it's going to take a long time to correct that. Not long ago I spoke to a class at Rutgers Medical School, and there were about 40 students, and I asked, by way of a show of hands, how many were going to go into primary care or family medicine, and 2 raised their hands. And the rest were going to do some other things. And that's great, but to have just 2 is really troubling. And so even if today we adopted the best program with tuition assistance and loan forgiveness, which, by the way, we do have some of that, it's going to take years to cultivate and graduate young men and women who will be primary care providers for the residents and the patients of the state. I've written laws and I've introduced legislation currently that would expand the scope of practice for advanced practice nurses. And anyone who thinks that, anyone who thinks that that isn't a viable solution and a thoughtful solution to expand the capacity for patients in the state is, I think, just wrong. Nurses have the ability and the training to do this work. We changed the scope of practice a few years ago to allow them to diagnose and prescribe, and now we're trying to move them a little bit more away from this tether that they have to physicians where it really doesn't need to exist, to let them work independently to the limits of their practice, limits of their license, and they do great work. We have the ability to do much better in our school systems and to do outreach and to actually put advanced practice nurses on the ground in these facilities. I've done some pilot programs in my hometown of Woodbridge, and it's been very effective, reducing absenteeism and reducing absenteeism in the school, but actually also reducing absenteeism in the workplace when parents have to take off from work because they have sick kids at home that aren't getting better faster, where they will if they were treated sooner. So there are a number of ways in which we can address the shortage issue. It's not going to be easy, it's not going to happen overnight, but if we don't begin to work on this somehow, some way now, we'll never get there. I think Suzanne's smart to say that we should manage our expectations. But it doesn't mean that there aren't enough smart people in this room and outside this room that can actually make a difference and make this work. Years ago, we didn't think that we could do any number of things in this state and across the country because it took too much work. Nothing that's worth something that's as valuable and important as this doesn't require that much work. It does. So, thanks.
Thank you. Ray, what are your
Yeah, I think there are a number of things that we need to do. I think the first thing is we need to, and I'm working with the New Jersey Healthcare Coalition, which, as many of you know, has been very active in the original federal legislation and has been very involved in the implementation of the Affordable Care Act. And I think one of the first things we need to do is a detailed study of the population that we're going to serve. Who are they and where do they live? And then we need to develop a comprehensive outreach strategy with specific enrollment goals based on that population, and we need to have different strategies for each group. I mean, obviously in terms of how we reach someone who's age 60, who was an engineer, lost a job, no hope of getting another job, so he has zero income, that person could be eligible for the Medicaid expansion versus a college graduate living with mom and dad who doesn't have health care coverage. So how you deal with those populations are going to be very, very different. The materials that you prepare, physically how you reach them is going to be very, very different. This is a very, very diverse population, and studies have shown that 78% of everyone who is eligible for the Medicaid expansion is not aware of that. And part of the problem here is that these children are eligible for the first time. I mean, we've never had this before, so they don't know exactly what Medicaid is, and they certainly don't know how to apply for it. So, and then once we have developed that strategy, we need to figure out, well, how much funding do we need? We need to identify that funding. And I mean, unfortunately, once we do that, I'm sure we're going to be able to get funding. It's not going to be sufficient. We have a huge demand. Then the question becomes, how can we marshal other resources? I think we need to look at, in terms of encouraging the public to be involved. I know in family care, there have been focus groups which have shown that most people know about this from their neighbors and their relatives. So we need to have a message out to the public that reaching out to these folks is really everyone's responsibility. And if we all, and only by working together can we really improve the health of our state. And also, I just wanted to add that on the Navigator program, the New Jersey for Healthcare Coalition is coordinating some of this. I suggest that if you want to be a navigator, I suggest, and we have folks from the coalition here, that you might want to contact that organization if you want to be a navigator. At some point, I can explain a little bit about the Navigator program as well, but I can do that later.
Thanks, Ray. Suzanne.
Yeah. Just a couple of comments. I think this Medicaid expansion is going to be more challenging than the family care expansion in the past because, as we all know, as parents, you do a lot for your kids that you don't do for yourself, right? And also, I think the point of contact, I think a lot was done through the schools. So you hit the kids there and you also hit the parents there. But now, as Ray said, you could have a 60-year-old person and you can have a college graduate. And so the point to touch those people is varied. So I think it's going to be a little harder this time around to enroll everyone. Now, for the hospitals, we are the point of contact if someone comes into the hospital. But I just want to give you a little perspective on why it's challenging to get everyone enrolled who comes in. There are federal laws called, there's an EMTALA law that says you have to treat everyone who comes in. And you actually have to triage them, and treat them before you're allowed to discuss anything having to do with how they pay or if they have insurance. So for somebody who just comes in and is an emergency room kind of treat and release patient, the hospital does its best to say, and now you are going into this room to discuss, what programs you may be eligible for. Some people don't go to that next room because they've already been treated. So I just want to put that little layer of reality there, because we do have the patient, we are the point of contact, but it's a lot easier to get them enrolled in Medicaid if afterwards they are, if they're admitted, you have them in the bed, the financial counselor goes to visit them. But if they're emergency room treat and release, the patient can just walk without actually, hearing the financial counselor out. So just a little dose of reality there.
Thank you. Dr. Aleg?
I think the rest of the panelists talked about some of the key issues that are actually going to be very critical in making sure that this is a successful implementation, because the state can only put together a blueprint, but the implementation and really coming up with the best practices is our responsibility. So when you come, in addition to the physician shortage issue, the important thing is how do we retain our physicians, because they're leaving the state. 32% of physicians who finish their residency actually practice in our state. So those are some of the shorter term solutions we're going to have to look at, whether it's malpractice reform or whether it's looking at loan redemption programs. But again, expanding the scope of primary care and getting other non-physician providers involved as part of the team is going to be critical. In fact, there's a lot of literature out there that talks about advanced practice nurses and nurse practitioners who do a much better job in primary care than even the physicians, because they spend the time. They do go through the preventative screening elements of care. So those are going to be some of the things we're going to look at: telehealth, telemedicine, EICUs, EEDs, things like that that we're going to be doing electronically are going to be critical. Obviously, we talked about the enrollment and engaging the community so that they do come onto the exchanges, because that's going to be your central single point of entry. And so how are you going to integrate that with the new insurance subsidies? But the important thing, at least for me, that I think is going to be critical stems from a discussion I had with a physician just last week. And he was telling me about this patient of his, had no idea how sick this patient was. And as part of the Accountable Care Organization initiative, we're getting all kinds of data from CMS right now. So he pulls up, the patient's supposed to be coming and seeing him, pulls up the data in terms of the utilization, and realizes that over the past year, this patient has utilized a healthcare cost of $220,000 with 20 admissions. And he had no idea that this was happening. So he gets back with the rest of the specialists who are taking care of these patients. They come up with a plan. They come up with a home care solution for this patient, put her into rehab, had lung disease, put her in an appropriate rehab program, and start managing the patient and start talking about palliative care. So this is sort of an example of what we have to do if the Medicaid program is going to be successful. We need transparency. We need data. We need data at the point of care to understand where the gaps in care are. How are we going to bridge it? What is the best solution? How fragmented is this care? And how are we going to bring all this together? And then to be reporting on quality, because it has to be competitive. We have to be looking at what is the best solution for what population segment. Something that we talked about earlier is, what is this population going to look like? How are we going to stratify them? How are we going to risk allocate them? What are those targeted interventions that are going to take care of those specific segments of our population for which we're going to get the best possible outcomes? Those are going to be key, and that's where we as a healthcare community will have to come together and make this seamless, in addition to being able to integrate behavioral and physical health. That's going to be critical if we're going to be able to succeed in Medicaid.
Senator Vitale wanted to follow up. Oh, okay.
You don't want to cut me off, Senator? Thank you, I appreciate that. I'll say nice things. I think it's really education, and really it's education for three groups. It's members, which we've talked a lot about already, and I'm not just saying this because Senator Vitale let me speak, but New Jersey's going to be a little bit different than other states in the fact that due to Senator Vitale's leadership, single adults in our state have had coverage previously. So is that going to make us a little bit different maybe than other states? And as I think about education for policyholders, you know, there are a lot of new variables out there that are going to change the dynamics in the marketplace. One, you've got the subsidies and the commercial exchange. Two, you've got other states that, even if New Jersey isn't advertising perhaps as much as we would like, New York is going to be, we would expect. What's that going to do? There's some other, you know, the consequence of the federal tax penalty, even though none of these people will actually have to pay it because the cost is far above the hardship level, how is that going to impact people in terms of their enrollment? So we're going to have to be agile in terms of adjusting to what are the effects of these policy changes that we've made. The other thing I would say about provider education, one of the important steps of the ACA is primary care doctors will get paid at 100% of Medicare. Now, it's only for a 2-year period. Frankly, it's taken a lot to get that off the ground, but I feel fairly certain a large number of providers don't realize that is supposed to happen. At some level, they don't realize it because it isn't happening, but once it does, and what does that do in terms of PCP availability, so on and so forth? And the last thing I would say, obviously, I think Senator Vitale and I would disagree in terms of the degree of PCP shortage in our state, but undoubtedly, as the senator points out, scope of practice here in New Jersey for nurses needs to be expanded. We're behind other states. Those sort of common sense changes should be made regardless of sort of where we stand in terms of supply. They do a great job. Why would you cut somebody like that out from the market? But for me, it's really education to those three groups.
Thank you, John. Senator.
I just want to follow up on two things. One, what Suzanne said and John. The first, I think we have to talk a little bit about accountability, because we have all these great ideas and programs in place now, and sometimes there just isn't accountability. So Suzanne talked a little bit earlier about, you know, really tracking down that patient who presents at the emergency room. You can't ask them out of the gate if they have insurance, although they're probably, some can be creative with that, but it's about what happens afterward. But, you know, we have an opportunity to gather that information, and we do that now, and we're supposed to be doing that in our schools. So when you know, parents send in that slip with all that information on the contact information, there's now a checkoff that we did that asks whether or not that parent has insurance, or whether the child has insurance. And then the state is supposed to follow up. You know, we could think about doing that in some of our hospitals or points of contact where people leave without answering the questions, but their information, I know there's some HIPAA issues, but we're not asking for something that's that dramatic, is they're not insured, that the state can follow up electronically through the hospitals and the information they provide to send those individuals applications or information about the program. But there has to be thoughtfully, you know, sort of designed and produced. Then it has to be accountability. And I say that because what's frustrating now, and we have this program which is, you know, family care, and, you know, we have told our schools and asked our schools that when you get that slip that says your child is not insured, or that student's not insured, that information is supposed to be electronically communicated to the state, and the state then sends the information to that parent. Cities like Newark and Camden and others, some of our biggest cities with some of the most uninsured children, are not doing that at all. And it's just, one fan. Not doing that at all. And so I'm going to maybe begin to address that issue. Why isn't it that they can't send that information that's on a database? This isn't about paper and work and having to pay someone thousands of dollars to send this information. Even if they had to do that, so what? But to send that information in, what are they waiting for? So you've got thousands of kids who don't have health insurance, and they could potentially have it, or at least some of them, if their parents had the information. So all I'm saying is that there has to be accountability in all of this. Accountability for me, who write these crazy laws, and then for those who provide the information and provide the services as well.
Right?
Yeah, I just wanted to follow up on that. And I think to support the senator here, when Andrew was talking about the 100,000 about who are going to go on the rolls, those are the childless adults only. Okay. Also, there are folks who are currently eligible where we expect an increase in enrollment, which is sometimes called the woodwork effect or the welcome mat effect. So as they hear about the program, more people are going to apply. And in the budget, the assumption is that many of these people are going to apply because of that, and also we have the individual mandate. So in addition to the 100,000 who are going to be at 100% federal matching funds, they estimate about 60,000 parents are also going to be going to enroll. So that's 160,000 adults, plus which more children are expected. I don't have those numbers right here. They expect a substantial number of children, and adults at the welfare level will be applying as well. So the total number who are going to be going on and going into HMOs is much, much higher than the 100,000. And I know we've been talking a lot about enrollment, but we also need to think about the other side of this, which is what kind of benefits are they going to get? And here there's a great deal of flexibility in the expansion. It's one of the most positive pieces of the legislation. I think it's in line with what has been said earlier, that we need to sort of transform Medicaid and look at it in a new way. The way we've done benefits in the past is pretty much follow federal regulation, some things you have to do, and then you have options that you may or may not want to do. Here we have very broad flexibility, and we have an opportunity to actually have a benefit package that is better than what is in Medicaid now, and we can target it to this group. I mean, we know a lot of these adults have substance and mental health problems. So why not target those services? And there are other services as well. So we should really look at this in a different way rather than just have a flat benefit package. Let's look at the needs of this particular population and then provide the services to meet those needs.
Thank you. John.
Yeah, if I might follow up sort of on Senator Vitale's point, I think he's exactly right in terms of the accountability, but also in terms of there's some very basic things we can do as a state that will make some very real differences. And one of them, as the senator is getting to, is demographics. How do you reach these people? What's the contact information? The state Medicaid Human Services Department has had a long-standing effort to improve their enrollment system, their demographic system. I'm optimistic that that will make real differences. A concern I have is just if you think about changes in the last 10, 15 years about how we all talk to each other, it's affecting the Medicaid population as well. They do use cell phones, but frequently they buy the disposable type, so the number's changing. And one of the key, a very simple thing, not necessarily a simple idea, but maybe difficult to execute, is if the state could store multiple phone numbers because these phone numbers change, our ability to get in touch with people is really vital to educating them. So I think the senator is exactly right. There's some very basic stuff that we got to do that can make a big difference, but we got to pay attention to it.
I wanted to return to the point you made about the increasing reimbursement for or payments to Medicaid for doctors who treat Medicaid patients. Now, my understanding is that that's already gone into effect in a sense, in that any care that doctors have provided since January 1st will receive that elevated level. But because of delays in the federal regulations, now there have been delays in the state regulations. So doctors aren't really aware of, some doctors are aware of it, but they're not aware of how it will work or when that will come in. Any thoughts from the panel on whether this will be significant in increasing the number of doctors who will treat patients who are in Medicaid?
Well, let me say a couple things first, if I might. One, you're absolutely right. So doctors already provided the services will get that payment. Unfortunately, you're also right, and it's true, I think, in all 50 states at this point. Nobody's been able to implement it at this point. The federal government's demanding some real accountability in terms of making sure that the feds are paying for this increase entirely. So there are accountability issues, and states have to submit plans to the federal government before that gets approved. So there's unfortunately a lot of gears in place that have to happen before the money gets out into the doctor's hands. In terms of whether it will work or not, I'm optimistic, but as I said before, in terms of need for education, this is one of those issues policymakers are going to have to follow and potentially adjust to. One of the big frustrations in our business is 50% of all doctors in New Jersey, if you call them and you say Medicaid, that ends the conversation. They don't want to have a discussion with you about how much we'll pay you. That's it. They don't want to talk about it. So hopefully this changes that percentage in some way, and there can be better recruitment. Whether that's going to work or not, that's just one of those unknowns, and until that policy's out there and in place, you don't know. But I do think it's vital, to Senator Vitale's point, accountability. We got to get this done, sooner than we've gotten it done so far. So, not sure, but hopefully it does have an impact.
I would agree. I mean, I think in addition to accountability, we really look at this from a more broader planning perspective. I mean, you know, a lot of in the Affordable Care Act, there are a lot of opportunities, but this is really a partnership with the state. You know, I agree that if all we're doing is simply increasing the paycheck, frankly, of primary care physicians, it's going to have very little impact. But we should really, and by the way, this is going to have, we're talking, I believe, hundreds of millions of dollars here. So this is not a small initiative, because New Jersey was either dead last or very close to dead last in the country. So it would appear the reimbursement rate is going to be about doubling. So that's very positive. But with this happening, we then need to have sort of a strategy of how can we use this as an opportunity to develop, you know, first of all, assess where the need is in terms of more primary care physicians, and then try to use this as a way to encourage physicians to participate in the program. Simply mailing a check to them is not going to do it. The state has to do a lot. I think the HMOs have to do a lot. I think the Medicaid division needs to have some accountability standards. We need to have some goals. So we need to address the entire issue of reimbursement and any shortage that might exist with respect to primary care physicians.
So again, being a physician and having talked to a few physicians about this, I've got mixed reactions. So some of them are excited because, again, to your point, we're amongst the lowest when it comes to our Medicaid fee schedule. And some of them, a lot of them actually, are saying, well, this is just a 2-year fix. So what's going to happen after that? Now I have a relationship with my patients. I can't abandon them. So should I even go into that? And my advice, as I'm talking about this issue, is that this is sort of the roadmap to how things are going to change and how we need to be making things like our Medicaid accountable care organization successful. So now, as a group of providers, we start looking at the care, the comprehensive care for these patients, and then at the end of it, if the projected savings if there are any projected savings, then everybody gets a piece of those projected savings if the quality measures continue to rise. Now, the Medicare Accountable Care Organization is based on that premise. And I have to tell you, the third-party payers, the commercial payers, have been really great at adopting what's happening in terms of changing how we're reimbursing for health care. And they've been the catalyst to what's going to happen in the next few years when it comes to making sure that we're paying for good outcomes, not purely for utilization. So if all we did was increase the fee schedule for 2 years, we've actually lost a huge opportunity. We have to do that in tandem to getting these physicians engaged, excited, and looking at those opportunities from the Affordable Care Act and seeing how we can mobilize it right here in our state and get the right partners together to be able to bring about successful results. So I see the next 2 years as critical in terms of shaping what our Medicaid reimbursement strategy is going to be.
For more information, visit the website NJSpotlight.com. We produce these programs in the studios of Lubetkin Global Communications in Cherry Hill, New Jersey, on the web at lubetkin.net. For everyone at NJ Spotlight, this is Steve Lubetkin. Thank you for joining us, and take good care. NJ Spotlight, where issues matter.